Yeah, we are live now, ma'am. Madhumita ma'am, please start.
Yes.
Yes,
You'll
good
be starting.
evening. This is the academic Pinnacle news series. The word news is from, I have selected the societies from North, East, West, and South. And I welcome you all, the delegates, faculties, and the society president and secretary. First of all, I should thank Dr. Hema Madam for accepting to be the chief guest for my first program. And Dr. Rosa Madam, from whom I was continuing my adolescent committee chair, for accepting to be the chief guest and guest of honor, Dr. Shubha Madam from Jaunpur Society and Dr. Datta from Thane Society. Hope they have joined. And when I thought to think, starting this program, immediately I contacted one society from all zones, North, East, West, and South. So we should thank that Jaunpur Society President Dr. Shubha and Dr. Shaili for accepting so within a short duration, hardly 10 days, I think. Then Dhanbad Society, Dr. Gayatri and Neha, President and Secretary, and Thane Society, Dr. Datta and Dr. Ujwala, and around South Society, Dr. Shanta Vibila and Nivedita for from Seni. So that's the reason we have mentioned it as Pinnacle News Series. So then we have that, I welcome Dr. Shanti Rani, who accepted to conduct the panel with the expert Shanta Vibala, and the panelists being the Abhurva Kumar Datta, Shaili Niham, Shikala, Ujwala, and Neha, Bhuneshwari, Nivedita, and Gayatri Singh. So now we will go with the, I hand out the mic to our MOC, the young and dynamic Foxian Dr. Madhumita from Salem. Yes, Madhumita.
Thank you so much for your kind words, ma'am. Now we'll move on to the prayer song.
Yes, now I have the pleasure in introducing Dr. Hema Madam, who is the chief guest for my series number 1. Hema Madam is the medical director from Divakar Specialty Hospital, CEO, chairman of Artist and Dean of KCOG Karnataka. And Madam has got many awards and of all this, Madam is the mentor and who is the well-wisher for me. So I thought for my first program, Dr. Hema and Dr. Rosa should be there. Welcome, Hema Madam.
Thank you so much. Namaste, everyone. And I think when I see the start with the Saraswati Vandana, I think God really connects the people who are meant to be on one forum, doing the right things. And Ma Saraswati is, of course, the goddess of knowledge or Vidya. And that's what Pinnacle is all set itself out to do. And oftentimes we also play the shlokas of Lord Vigneshwara, which means there are so many things one aspires to do, but they may have many barriers and obstacles. And we say, Lord, save us from those. So these are actually in the forefront. And what everybody, as in the transactional world desires, the Lakshmi, follows automatically if you're doing things right. That's what I feel, that in the context of the belief that we in our culture have. And Rosa, my very, very beloved friend from ever since I remember, she's been an adolescent. It's because the beautiful work that she has done for this committee, which has helped the adolescents grow into the whole circle of life, into the pink of their health, if I may say. And thereafter, the baton passed on to chairmen of many adolescent committees. And in that journey, it was swept away by somebody called Dr. Sampath Kumari, who also did a phenomenal amount of work, which led her to the next level of being the vice president of Foxy. Now we aspire to do more, reaching to the pinnacle post in our parent organization without any hesitancy and modesty, I would say, that somebody who deserves to be at the pinnacle of affairs and who will make news, the waves of news, for the phenomenal work that she would continue to do for the organization, none other than Dr. Sampath Kumari. I really respect her sentiments for having invited me to kickstart the Pinnacle news program. And I was just looking up, as it's typically my tendency to do, what does the word news mean? Well, we have turned it around for this program. And you'll see the 4 colors in the flyer that you have been sent. N is for North, Jaunpur. E for East, Dhanbad. West is Thane. And South is Teni. Very well curated into those 4 colors, and the 4 boxes contain the leaders from these regions whom we very, very fondly welcome, because we believe, and definitely with Sampath in the forefront, we believe it's all inclusive. Together we can and we will. And the actual word news originated from saying something new. And the S got added onto it, and it says the news. So that is the origin. But we always think out of the box, and getting the North, South, East, West from our own country together to have a common intent and join hands for the synergies that we can bring in for so many things that we ought to do for every girl, every woman, everywhere, every time. This stage is set for many, many more things. So we will remember the 12th of December, the 12th month of the year in 2024, 24 doubling into 2 times 12. So it is, the number play is also very much inherent in the date that she has chosen for the start of this program. So on behalf of the guest of honors whom we are honored to have here, and my very beloved friend Rosa, and my own self, and all the Foxians, we wish a brilliant start to this program. And anybody who wants to climb the ladder is always tense, but our message to Sampath is chill. Just be cool, because you will do a lot more together with us. And we do wish that this program on hypertension, I told you that don't be tense and don't be, but you be hyper in your activities. So the hypertension series is also the right fit for the program today. With that, once again, with my humble and heartfelt congratulations to you for thinking of starting this series, and also respecting the sentiments that the attitude of gratitude that you have for your mentors, which is also very, very, very well, appreciated by the likes of me and Rosa. We wish you all the very best and the best of learnings to all those who are participating in this program. Namaste, and thank you for having me here.
Thank you so much, madam. Thank you, madam. So I should keep up all your words and do the good work. Thank you. Next, Sahiti, can you put we have the next chief guest, Dr. Rosa Madam. Dr. Rosa Madam is the director of Lai Hospital and president of Gwalior Society. And she was chairperson of HBC Madhya Pradesh, and she was the chairperson of Adolescent Committee, FOXY. From there only we started, I think, when she was the committee chair only, I started working with Dr. Jayam Kannan, and Jayam Kannan Madam was a South Zone coordinator. So I was started working with Rosa Madam. From that only I started to become a committee chair of Adolescent Committee. Welcome, Rosa Madam.
Thank you, Sampath. I would like to speak a little more than being introduced. I think what you started off with Dr. Hema Devakar as your chief guest, one of the very best choices, I must say. The way Dr. Hema just spoke, and it was really, my thoughts were in the same direction. I think Dr. Hema, we are in the same mindlet, I love the way you started it off with a spiritual note. And in my mind, I never came with any prepared speech, but what came to my mind is from my holy writings, the holy writings, which I always tell my patients, my younger adolescents, my children, that it says man's merit lieth in virtues and service, and not in pageantry of wealth and riches. The adolescent, the youth of today should know all this. And what Dr. Hema made a beautiful journey for Dr. Sampath. Hema, I must say that you were the very first person in Foxy I was introduced to, and you do remember that you helped me with my publication. I was just new to Foxy perinatology, and with that I was able to get into FICUG, and then the sky was the limit to get into Foxy. So thank you, Hema, for being always with me and encouraging me to go higher and higher. I do appreciate all the good work. And yes, what Dr. Hema really has a support for you, Sampath. My sentiments are with you. I have seen you grow a little more closely in the adolescent, fraternity as a chairperson. And I must tell you, yes, the previous chairpersons, all of us did a lot of work, but you took it into a different level by going literally to a lot many schools and colleges. The way you brought up this committee into another level was, honestly speaking, really remarkable. It's not just because I'm trying to tell you in front of everyone, but I must say that what I've been saying, you brought it into a different level of going and getting into large number of adolescents. You did a wonderful job in Tamil Nadu, I remember. I was closely observing your work, and you won the best award from the chief minister. So these are part of the good work you have been doing. And what I like in you is not only the good work that you do, but the gold heart that you have. You see, when we select, I must say, a leader, I think importantly, Dr. Hema, I see her as a past president of Foxy. And of course, in FIGO, she's of course doing a lot of work and being the chair. But what we see a quality, I see the same with you, to have a golden heart and a good human being, which is more important. It is equally important than being an academician, being a good leader, trying to bring people together. If they love you, they come to you. Remember that. So I think I see those qualities, Dr. Sampath, with you. And as Dr. Hema Devakar said, you shouldn't be tense about it. However, yes, you're going to be actively involved in meeting and having such communities get together. Now, getting 4 societies together on a platform that we see today is not a joke. It's so nice that I see that all of you, dear friends from different areas, you've come together. And of course, my co-guest of honors, we are sharing the same platform, that I must really congratulate all of you that, you've been trying to get together and learning things about the burning issue, which is hypertensive disorders of pregnancy. There are a lot of, myths about magnesium sulfate, the treatment, the latest updates, which I think Dr. Hema had also worked so hard towards that, justices, and many things you're involved with. So I think this will be a very good platform today to learn, especially for the gynecologists, who are generally practicing, in smaller nursing homes, when to give magnesium sulfate, what dose, what is calcium gluconate, how is to be given, when to be given, what are the side effects, different antihypertensive medications which are now available, and we should have the confidence to go forward and look. So, I'm sitting in a room where my granddaughter is playing the piano and children are all around me. So this is what life is. These are my sister-in-law's children. My own grandchildren are in Australia. You know, Hema, my kids are in Australia. So, Sampath, I won't take your time away, but from my heart, I want to support you, wish you all the very best. And if there is anything we can do, we are always with you. Go ahead. We need leaders like you. God bless you. And thank you so much for inviting me. Thank you.
In spite of you are in your sister-in-law's house, you have joined us. Similarly, Hema madam, it's very difficult to catch her. Immediately she accepted. 10 days back only I told her. Anyway, thank you, Hema madam and Rosa madam, for joining this task. Madam, only 1 minute. That lamp lighting we didn't do. That alone we will request the dignitaries to join this lamp lighting. Sakshi,
Yeah, and your FIGO position I forgot to tell, so it gives me one more chance because she is in the FIGO Adolescent and Youth Committee, and she is a forerunner in that group too, because the most committed, most enthusiastic, all the FIGO group is suitably already impressed, and we will do more together on the global platform as well. So
Congratulations, Sampath. That's something, another feather to your cap. So you are the best person to be selected. And thank you, Hema, for supporting her. Thank you.
join the lamp lighting. Yes, Sakshi. Thank you. Thank you, madam. Next, I invite our guest of honor, first Dr. Datta. She is the practicing gynecologist and endoscopic surgeon at Thane and MD from Grants Medical College, worked under Dr. Kamal Deshmukh and first MD exam in Bombay University and Secretary IMA 93 to 2000, President IMA 2015 to 18, Secretary General Talks 2020 to 21, and he has got many awards and invited speaker in many conferences. Welcome, sir, and I welcome you for a few words and for accepting as a guest of honor on today.
Yeah.
Welcome.
Thank you, madam. Thank you very much. You have always been at the forefront of Foxy activities, whether you are a chairperson or a vice president. You've always been there, and you are one of the few people who has been academically oriented. So whenever you are there, there is something we always learn from you, and it is so kind of you. We are really honored that for your first Pinnacle webinar, you have chosen the Thani Society from the West Zone. So we are really honored and we are so happy, both me and my secretary Ujjwala, who is also going to be a panelist. So we are really thankful to you, and you have chosen probably the best subject to kickstart your Pinnacle C, which is hypertension, which most people want to know, because this is something which we deal every day. Hypertensive women coming with HELP syndrome or with eclampsia, these are women we deal with every day, and there are so many ifs and buts and so many things that need to be clarified. And I'm sure at the end of the webinar, with all the experts and the expert panelists, all our doubts will be cleared. Thank you very much. And from me, my secretary and the Thani Society, we wish you all the best for all your future endeavors. Thank you very much. Thank you.
Thank you so much, sir. Thank you. Dr. Shubha is there, I think. Dr. Shubha is there, no?
No, my ma'am is not able to join, ma'am. It's
So,
an emergency. She's not able to join.
thank you, Hema ma'am, Rosa ma'am, and Datta sir. Now we will go with the scientific session. Dr. Madhumita, you can take over. Thank
Yes,
you.
ma'am. So moving on to the much awaited scientific session. We have two sessions. For the first session, we have a talk on hypertensive disorders in pregnancy update by Sampath Kumari ma'am. And for the second session, we have a panel discussion on case-based scenarios. For the first session, I invite our chairperson, Dr. Gayatri Singh, who is the president of Dhanbad Obstetric and Gynecological Society. She's a senior consultant working in Dhanbad, and she's also the ex-CMO of Obstetric and Gynecology at Central Hospital Dhanbad. We very happy to welcome you to today's program, ma'am. Request you to please introduce Sampath, ma'am. Ma'am, you're muted, ma'am. Gayatri, ma'am, you're muted, ma'am. Gayatri, ma'am. Ma'am, you're muted.
Can you,
Yes, yes,
can you
ma'am.
hear me? Yeah.
Yes, ma'am. Yes, ma'am. Can you start?
Good evening, ma'am. Good evening, our chief guest, Dr. Hema, ma'am, Dr. Rosa, ma'am, and Dr. Panikar, ma'am, sir. And it's my pleasure that I'm very humbled that you, Dr. Sampath, ma'am, has included us, Dr. Dhanbad Ops and Gynae Society, in your in the so much programs Pinnacle. That is so much knowledge to be shared with everyone in the Foxy. It's really very nice thinking of the ma'am. I would like to welcome Professor Dr. S. Sampath Kumari ma'am. She is the Foxy, our Foxy Vice President in 2022, Senate member. She's also a Senate member, Tamil Nadu Dr. MGR Medical Universities. She's a National Corresponding Editor, General Ops and Gynae of India, Jogi. Founder Secretary, Tamil Nadu Federation of Ops and Gynae, TNFOG, retired Deputy Director, Institute of Ops and Gynae, MMC Chennai. She's our President, Board of Studies, Ops and Gynae, Tamil Nadu, Dr. MGR Medical University, 2015-19. And she was the first ICOG Distinguished General Council Member Award. She has won in 2021. She is also the chairperson, Women's Wing, IMA Chennai South. She is IMA National President. She got IMA National President's Award and IMA TNSB Award 2021. So many feathers in your head, ma'am, in your cap, ma'am. You are really a very learned person, and we would like to hear from you. And I would like to welcome you, ma'am, for your esteemed speaker, Madam Sampath Kumari, ma'am. And so, over to ma'am, sir, ma'am.
Thank you, Gayatri, ma'am.
Thank you for giving this opportunity, being a chairperson, ma'am. And your thought is so much broad that I really appreciate. And Dr. Hema, ma'am, as said by the Dr. Hema, ma'am, your thinking and thought involving all the east, west, north, south, making a circle is really very, very nice thinking, ma'am. Nice. Welcome you, ma'am. Today is our Pinnacle. I'm very happy to be a chairperson as a chairperson. Nice, ma'am. You are so learned, very nice. I would like to hear from you. And we all are very get knowledge with all this. Your knowledge.
Thank you so much. With all your support, we can do a good work.
Yes, yes. We will support you, ma'am.
Teacher class, I'll share my slide.
Pardon?
Okay, madam.
Yeah, please continue, ma'am. Over to you.
Sakiti, can I share the slide? Madam, we close the video now.
Sarthi, can you allow screen sharing?
Yes, ma'am. Ma'am is co-host only.
Ma'am, you can start sharing. Yes, ma'am.
Good evening to all. First of all, thanks to everyone who has joined. Hema madam, Rosa madam, Datta sir, Gayatri madam, and all the delegates and the Shantirani, the moderator. See, there is no end to learning, but there are many beginnings. So always we should learn whatever is possible and update. Today, I have taken the topic of hypertensive disorder in pregnancy. See, the hypertension which develops after 20 weeks of gestation and continues till the 6 weeks of the postpartum, that we called as gestational hypertension. It occurs in 5 to 10% of the pregnancies. This is the ISSHP classification, which mentions that hypertension in pregnancy before 20 weeks and after 20 weeks. Before 20 weeks, we called as, but that is a hypertension patient becoming pregnant. That is pregnant patient going for hypertension, that is after 20 weeks. That is before 20 weeks is chronic hypertension, which is essential and secondary, white coat hypertension and masked hypertension. Most of the time when the patient see the white coat, the BP will get increased. So that we have to make her take rest and again we have to examine. And after 20 weeks is mainly the gestational hypertension. When it is with the proteinuria, it is preeclampsia. And then this chronic hypertension can be superimposed with the preeclampsia. So this is the classification gestational hypertension between 0 to 20 weeks. And if it is associated with proteinuria, it is preeclampsia. When we don't diagnose this situations, it ends up in the eclampsia, and it can be superimposed with chronic hypertension, which occurs from the earliest stages. So as per Foxy, gestational hypertension, BP more than 140/90, more than 20 weeks, and normalizes after the 6 weeks of postpartum is gestational hypertension. Chronic hypertension, which is the hypertension before 20 weeks, and preeclampsia, it is the multi-system inflammatory disorder. Beyond 20 weeks, it may be with proteinuria or may not be with proteinuria. Non-severe preeclampsia, most of the time BP is 140 to 160 and 90 to 110 without the end organ damage. Severe preeclampsia is more than 160 by 110 with the imminent signs, that is the premonitory symptoms and the abnormal lab findings. So the symptoms being the headache, blurring of vision, right upper epigastric pain, that is right upper quadrant pain, and reduced urinary output, excessive weight gain, and severe edema. So the lab findings being low platelets, elevated liver enzymes, elevated serum creatinine, and abnormal coagulation profile. So nowadays, the early onset preeclampsia, we call when the gestational age is less than 34 weeks with all these findings. And when the onset of hypertension occurs after 34 weeks with proteinuria, it is late onset preeclampsia. Then the atypical preeclampsia, where the associated symptoms, the neurological, hematological manifestations, IUGR will be there, but there may not be a proteinuria, and sometimes BP may also be normal. Under the superimposed preeclampsia, it can be superimposed with the chronic hypertension. Finally comes the eclampsia, where the occurrence of seizures in association with the preeclampsia. So normally the vasoconstriction, the pathogenesis is the cause for hypertensive disorder. Once the baby is delivered, placenta is out, everything is normal. So in the preeclampsia, these are all the possible symptoms which can be involved: proteinuria, kidney injury, liver involvement, neurological complications, hematological complications, and uteroplacental dysfunction. See, with the maternal mortality, now we are this anemia, we have the iron sucrose and the ferrous carboxymaltase. So similarly, the maternal mortality, nowadays most of the things has reduced, and our MMR has reduced in India and the South, wherever it is. But still the main cause for maternal mortality in our place and everywhere is hypertension. And second is PPH. We do not know which patient will go for hypertensive disorder complicating, and after delivery, which patient will go for PPH. So the maternal mortality with the hypertension means the correct monitoring of the BP is very, very important. The BP should be monitored with appropriate curve in the left lateral position or the sitting posture with the both heart border, BP apparatus, everything in the same level of the line. So gestational hypertension, when it is after the 20 weeks, in this case, the growth restrictions will be less, and BP normalizes after the 3 months of the postpartum. Most of the time, the gestational hypertension is not associated with proteinuria. So whenever there is a patient we diagnose after 20 weeks, the hypertensive cases means monitoring the BP is very, very, very important. And we should ask the 5 leading questions to the patient. Most of the time, they will not come out with the symptoms. So whether they have the headache, prominently frontal lobe headache, not relieved by taking analgesics and taking rest, blurring of vision, which reduces the retinal vasoconstrictions, upper abdominal pain, we should not think it as gastritis. When it is associated with a patient on antihypertensive and hypertensive disorder means we have to think of help. And reduced urinary output. Patient will not tell about the urinary output. We have to ask whether the urinary output which is reduced from the previous day. So these 4 questions should be put. Then only we can come that if it is not there, it is a gestational hypertension. If any of the symptoms is present, means it will go for the preeclampsia. Finally, as far as the maternal hypertension concerned, we are much bothered about the mother. Finally, we will ask about the fetal movement, where there will be the placental constriction, reduced placental transmissions. So what we are going to do, the medical management, the treatment for hypertensive disorder in pregnancy is labetalol. It's available as 100 milligram tablet. It can be given depending on the BP. We are going to do the BD-BP chart, OD once or twice or thrice a day. The other drug, when the BP is not controlled, that is when it is not comes to 140/90 with Labetalol means the next drug we are using is the nifedipine. It is available as 10 milligram capsule. Previously, we had the tablet of 5 milligram, which can be given under the tongue. Nowadays, it is not used. The main complication with the nifedipine is hypotension. The other drug, the alpha-methyl-dopa, which are not used in the postnatal cases because it has a long action. It does not have the quick action. Mostly, we use the tablets of labetalol and nifedipine. These are all the tablets available. Labetalol maximum dose of 200 milligram can be given. Nifedipine, the slow-releasing calcium channel blocker, hydralazine and hydrochlorothiazides and beta blockers. These are all the different types of tablets we are using for hypertensive disorder and pregnancy, and we don't use the ACE. Suppose the BP is very high. It is more than 200 by 160 like that. In that case, we go with the labetalol. Even in the injection form, labetalol, it has to be given. It is available as 100 milligram per 20 ml. Each ml is 5 milligram, 20 milligram IV bolus to start with. And we should monitor the BP after 10 minutes. If it is not reduced, increase the dose, double the dose. 40 milligram should be given. Monitor the BP after 10 minutes. Again, if it is not reduced, double the dose to 20 milligram, such that up to 220 milligram, we can increase the dose and stabilize the BP. Then through the Riles tube, we can, if the patient is conscious, you can go with the oral tablet. If she is not conscious, with the Riles tube, you can go with the oral and labetalol tablet. The proteinuria always you do with the sticks, whether the changing of the colors, mild, moderate, or severe. The detection of urinary protein 300 milligram per 24 hours. Nowadays, this is not done. And the specific protein creatinine ratio 0.3 milligram. These are all the tests which we confirm for the proteinuria. If proteinuria is present, it is called a preeclampsia severe. In the minor cases, we may not have the preeclampsia. Only with the severe preeclampsia, the proteinuria will be present. Suppose the patient is having the high hypertension and BP is increased and she is having the symptoms, as I told, headache or blurring of vision, we should think of end organ damage. So in that cases, we give the antihypertensive tablets, which I have mentioned, and we have to start the magnesium sulfate regimen. That is the pit chart regimen, which can be done even in the rural places like the primary health centers. The loading doses being IV for magnesium sulfate, 4 gram 20%, and IM 10 gram 50%. This is the magnesium sulfate. Each ampule is 2 ml. Each ampule is 1 gram. Each ampule is 50%. To make into 20%, we have to take a 20 ml syringe, 4 ampules of the magnesium sulfate, mix with the 12 ml of distilled water and give slowly for 10 minutes. That is the loading dose of IV. To make the 50% to 20%, we are adding with the 12 ml of distilled water. Then the IM being the 10 milligram, the 10 gram IM, that is the 50% itself. Each ampule is 1 gram, I told. So 5 ampules, 10 ml should be given in the right side gluteal region and the 10 ml should be given in the left side gluteal region. This is the loading dose we are giving. And if the patient is having pain, means we can add 1 ml of 2% lidocaine in the syringe and it can be given IM. And how long we are going to continue this? The maintenance dose. Every 4 hours, we have to monitor the BP. And this dose should be maintenance dose of 5 milligram magnesium sulfate 50%. That is 5 ampules, 10 ml. In the alternate buttocks, it's the 4 o'clock if you are going to give on the right side, at 8 o'clock we have to give on the left side. So alternately used for 24 hours after the last fit, after the delivery, it has to be done. So IV of 4 gram 20% and 10 gram IM maintenance loading dose and the maintenance dose of 5 milligram magnesium sulfate 50% for 24 hours. In between these 4 hours, we have to monitor the respiratory rate, urinary output, and patellar reflexes. If anything is reduced, suppose respiratory rate is less and output is 10 ml means, you can skip the 8 o'clock dose and you have to start at the 12 o'clock. The magnesium sulfate regimen has to be continued for 24 hours. The serum magnesium nowadays we are not doing, so we can do, but there is no facility to do everywhere. With this, depending only this loss of knee-jerk respiratory arrest, cardiac arrest will happen. So if anyone is reduced, then we are going to skip the dose and continue the drug. If magnesium toxicity is present, we are going to give the calcium gluconate. Suppose urinary output is 10 ml only, we are skipping the dose and give the antidote. This is the antidote for magnesium sulfate, 1 gram. That is in a 10 ml of 10% solution. We are going to give this magnesium sulfate. It is available as 100 milligram. That is, this is wrong, this 100 milligram, sorry. This 100 milligram has to be 10 ml means it becomes as a 1 gram. So these are all the symptoms. So when it is only BP is raised and the patient is under control and the monitoring of the baby is very, very important. After 32 weeks, we are going to do the CTC every 4 weeks. and monitor the baby's conditions. For that, we are going to give the antihypertension. If any imminent signs is present, we are going to give the antihypertension and the magnesium sulfate. So the early onset, as I told before, 34 weeks, late onset being 34 weeks. See, this is the prediction of the complications. That is the PREP collaborative network, which tells that whether there is a complications will be present or not. So if we don't identify the patient with the hypertension and the preeclampsia, next time it goes to the eclampsia. Most of the times our BHNs will come from the peripheral telling that we were monitoring, but the patient threw fits in the morning. But without the imminent signs, eclampsia is very, very difficult. If the patient comes with eclampsia, always call for help and airway, lateral decubitus position, put the suction and remove the secretions, give oxygen 6 liters per minute, and the breathing has to be established with, if at all needed, with the ventilations and the circulations on both the lines. IV should be taken. When you do the IV, get the blood sample for renal function test, liver function test, coagulopathy, and then go with the magnesium sulfate. Both the hands, we should have the IV catheters and the drugs. Drugs being it can be the magnesium sulfate and it can be the IV labetalol. So when you monitor all this and stabilize the patient and then do the vaginal examination and see whether the patient is in labor or not, depending on that, you can deliver it. So sometimes the patient, hypertensive disorder pregnancy patient comes with a complaint of upper epigastric pain, means we have to think of the health syndrome. It can be hemolysis, elevated liver enzymes, and the low platelets. So this is a classification, Mississippi classification. Again, here the treatment is control the hypertension, give the magnesium sulfate regimen, and the blood transfusion, depending on the platelets, the bloods are whether platelets or PCV, whatever it is needed. It has to be given and stabilize the patient, and then you plan for the delivery. So if nothing is treated, means the complications which can happen with this type of cases is abruption, visual disturbance, intracranial bleeding, pulmonary edema, oliguria. Most of the time, the visual disturbances will recur after the delivery. The baby complications being the placental insufficiency, growth restrictions, preterm, hypoxic neurological problem, low birth weight, and the perinatal data. These are the complications that can happen for mother and the baby, and the recurrence of the hypertension in the next pregnancy is 30%. So delivery, when are we going to do with no complications? Patient is stable, means we can wait till 37 weeks, no urgency. And in case of preterm pregnancy, you can wait if the patient is stable, means for the effect of the steroids, and then you can deliver. And if the gestational age is less than 24 weeks, means we have to deliver. And the approach should be individualized from 24 to 33 weeks. And if the patient is with eclampsia or HELLP syndrome or chronic hypertension with the superimposed preeclampsia, first stabilize the patient, correct the hypertension, give the magnesium sulfate, stabilize the patient with ABCD, and then plan for the delivery. So what is this PIH state should be kept in always in all the places, in the labor ward, in the theater, and in the antenatal ward. Gloves, magnesium sulfate 16 ampules, 10 ml syringe, calcium gluconate, lignocaine, knee hammer, 20 ml. These are all the set which should be kept ready, and we cannot search for these things once the patient is having the eclampsia. Now the patient delivered and she was on antihypertensive treatment and continue the antihypertensive treatment, and complaints of headache on third day with a BP of 160 by 110 means, again, we can think of do the MRI and see that nowadays it is very common posterior reversible encephalopathy syndrome. This is depressed, but this is same like hypertension only. Control the BP, give the magnesium sulfate, admit the patient, and it will go within, it is only a temporary problem, and it will subside within as BP and magnesium sulfate is given, it will become normal. So this is the complications which can happen. This is the MRI which tells about the pressure. So coming about the prediction. Say, as per WHO, prediction means whatever test is done, it should be a non-invasive, rapid, easy to carry, and it should be done by the all people. So previously we had this mean arterial pressure and the rollover test. These were all the prediction tests. That is a diastolic BP plus 0.33 into pulse pressure. When there is a difference of 90, we consider that they can go for hypertension after 20 weeks. There are a lot of markers, urinary markers and the blood markers are there. But we can useful markers at 19 to 25 weeks is the uterine artery Doppler, serum PLGF, that is growth factor, and the soluble SFLT. These are all the markers nowadays which are soluble FMS like tyrosine kinase. These are all done if the patient is affordable and if the hospital facilities are there. These markers can be done at 90 to 25 weeks. So these are all the predictors. And this is the SFLT will be increased in and PAIGF if it is decreased means these cases are prone for PAH in future. And SFLT by PAIGF ratio is also elevated. This is the prognosis study which mentions that SFLT by PAIGF ratio, if less than 38 means it can wait for next 27 days. This is the ratio. If it is less than 38, follow up. If it is 38 to 85, follow up for 1 week. If it is more than 85, means we have to deliver. Then this patient will go for preeclampsia and eclampsia. This is the Pelican study, which tells that this growth factor value should be less than 100 picogram per ml. These are all the study which mentions about the predictors, which can went to Delhi, what are all the complications can be there. This is the full 5 years model. This is with the history and the examinations. Whatever this full main thing is gestational age, presence of dyspnea, SpOT, platelet count, creatinine, and AST and SpOT. With these levels, we can see the model. This patient, whether she will go for complications or not. With these complications, the FOXY is having the gestosis score. It is more or less like a full 5 years model only. This gestosis score that we have to give a minor and major 1, 2, 3 points. That is the history of a previous PAH, GDM, like that. If any history like this, the risk factor, if these are all the risk factors with the score 1, score 2, score 3. Depending on that, we can predict the patient is going for in future for the complications. In Tamil Nadu, for all antenatal patients with hypertensive disorder, we do this gestosis score. And even for the normal patients, you can see, and if this patient can go for complications can be identified. So finally, the prediction and prevention, no test can predict the development of preeclampsia. And the first trimester screening can be recommended if the hospital is having the facility and the patient is affordable, and the risk factors has to be monitored. This is by simple the gestosis score. If you monitor, you can know that the patient will have the complications in future. If the complications is present, means you can go with the low dose aspirin 162 milligram. That is before the 16 weeks in the next pregnancy. And estimation of PAIGF, SFLT by PAIGF ratio for clinical trials. This is not routine. Only PAIGF is not so sensitive. With this ratio only will be very effective. And regular exercise and the diet lifestyle is the very, very important thing which has to be monitored. So finally, conclusion. Monitor the BP properly. That can alone reduce the incidence of complications. We cannot know whom will go for the preeclampsia and eclampsia, but we cannot prevent this also. So monitor the BP, and from the BP monitoring, you can avoid the complications. Follow up the patient. If the patient is not coming, here we have the pick me number, like that you will be having the number. Ask the VHMs to give a call and ask whether the patient has come for follow-up or not. Control the hypertension with antihypertensive, preferably lebitalol and nifedipine. If high dose means you can go with IV nifedipine, and prevent the complications. If it is a hypertensive patient, ask these 5 questions. Headache, blurring of vision, upper epigastric pain, reduced urinary output, and finally the PT movement. If it is present, we can catch them and terminate if needed, and we can prevent the complications. Whenever, if you don't have the facilities, and if you want to refer the case to the higher center where ICU facilities are there, stabilize the patient, give antihypertensive, give magnesium sulfate full dose, and document everything and refer the patient at the earliest stage. So if you monitor with the BP, we can reduce the mortality of hypertension. Thank you. Thank you for this.
Thank you for such a wonderful and informative talk, ma'am. Gayatri Singh, ma'am, can you give your concluding remarks, ma'am?
Yes, it is a very nice and elaborate information given by the madam, and it's very nice, very wonderful, and very crisp. But she has covered all the necessity things which we should look for in the hypertensive disorders in pregnancy. It's a very, very nice, madam. It's a wonderful talk, and everything has been covered by ma'am. So I think all of the listeners we have here who are attending must get some good knowledge with the madam's talk. Very nice, good ma'am. Thank you, ma'am. It's very wonderful talk, ma'am.
Thank you, madam. Thank you.
Thank you so much, ma'am.
You have covered everything, ma'am, in a very short but brief and a very crisp manner. You have covered everything and each and every aspects of the hypertensive SDP in pregnancy. So very nice, madam. Thank you, ma'am, for your talk.
Can I just intervene? I especially waited to hear you, Sampath. And very, very well covered, I must say. And I really, from the bottom of my heart, all support with you. I wish you all the very best. If you allow me, I'll take leave now because I have to go. And I wish all the chairpersons, all the faculty, all the best. Thank you so much for being here. Thank you. Lovely. Take care.
Thank you so much for joining us, ma'am. Thank you. So moving on to our second session, we have a very interesting panel on hypertensive disorders in pregnancy, case-based scenarios. We have our moderator, our dearest Shanti Rani ma'am, who's the past president of Teni Obstetric and Gynecological Society. And ma'am is well known for her very good organization and coordinating numerous programs in and around Tamil Nadu. We're very happy to have you as the moderator for the panel today, ma'am.
Thank you, Madhu.
Yes. We have our expert, who's the Shanta Vibala ma'am, who's the present president of Teni Obstetric and Gynecological Society. And ma'am is also the associate professor of Department of OG at Teni Medical College. Happy to have you as an expert today, ma'am. And we have 8 vibrant panelists today. Apurva Kumar Datta sir, who needs no introduction, who's the present chairperson of Fox Sexual Medicine and STA committee. And he's also the, I think this is past CV, I think. And he's also the regional faculty and master trainer of TOT, Foxy IAP initiative. And he's also the executive founder member of Jharkhand State Chapter of International Spina Bifida Foundation. And he's a winner of numerous awards from Foxy. Welcome, sir. Our next chairperson is Dr. Shaili Nigam ma'am, who's the secretary of Jaunpur Obstetric and Gynecological Society. Ma'am is a very vibrant person here, and she's also the director and consultant of Himani Hospital at Jaunpur, and she has numerous awards and publications to her credit. Welcome, ma'am. Her next panelist is Dr. Shika Shukla, who's a consultant at Tirthraj Hospital in Jaunpur, and she's also executive council member of Jaunpur Obstetric and Gynecological Society and also of UP Obstetric and Gynecological Society. Welcome, ma'am. And next panelist is vibrant Dr. Ujjwala Bhartapurkar, ma'am, who's the secretary of Thane Obstetric and Gynecological Society, and she's been bestowed with numerous awards, especially the President Appreciation Award from the Maharashtra State IMA Science, and she's also she has numerous awards to her credit. Welcome, ma'am. Next panelist we have Dr.
Madhumita,
Yes, ma'am.
previous page you go. Sakiti, previous slide.
Yes,
You
ma'am.
forgot this, Madhumita, she is the winner of Mediqueen Mrs. Maharashtra.
Oh, Maharashtra. That is lovely, ma'am.
Yes.
Oh, yes, ma'am.
Okay.
And our next panelist, we have Dr. S. Nivedita, who is a secretary of Teni Obstetric and Gynecological Society, and she's also the assistant professor of Sri Muthukumaran Medical College and Hospital in Chennai. And welcome you, ma'am. Next we have Dr. Bhuneshwari, who's the who's a consultant at gynecology at Teni, and also the assistant professor of Department of Obstetric and Gynecology Medical College in Teni. And welcome, ma'am. Next we have, I think Dr. Neha is not able to join today. So looking forward to a very informative panel. Shanti Rani ma'am, can share slides.
Yes. Thank you, Madhu, for the nice words.
Yes.
And shall I share my slide?
Yes, ma'am. Sure.
Yes, ma'am.
Shanti Rani, Valliya.
Not able to share, ma'am?
1 minute.
Yes, ma'am.
Ma'am, at first, please open the PPT, ma'am.
Yeah.
And then click on share. And then click on PPT tab and then share.
If your slide open on the screen, ma'am.
Yeah, 2 minutes, please. Desktop.
My sister is always finds every time.
சுதந்திரனை நீங்க அனுப்புறீங்களா இல்லைன்னா
Madam, வந்துருச்சா?
No,
You're
ma'am.
able to see.
You need to click on share screen, ma'am. Share option and then share.
Down, there's a green, no, ma'am, and green share screen. Just click on that, ma'am.
இன்னும் நீங்க வாட்ஸ்அப்ல அனுப்புங்க, நான் வேணா ஷேர் பண்றேன்.
Okay, madam. It's included.
In the meantime, if any doubt,
Madam, I have sent it to you.
எனக்கு
You can see
அனுப்பிச்சிருக்கீங்களா?
that. Shall I send to Sakti? Shall I share in group?
ஆசித்துக்கும் அனுப்பிச்சிடுங்க, பார்க்கலாம். அதை நான்
குரூப்ல போட்டுருங்க.
இதுதான் முதல்ல ட்ரையல்.
She loves.
Shall I send it in group?
Yes, ma'am. Sure, ma'am.
Yes,
Yes, ma'am.
மதுமிதா கூட எடுத்துருவா.
Yes, ma'am.
எப்படி போடுறது? Slide share பண்ணுங்க.
மதுமிதா நான் குரூப்ல போட்டேன், அதை அப்படியே ஷேர் பண்ணிடு.
Yes, ma'am. Sarthi, can you share the slides?
Yes, ma'am.
Madam, வந்துருச்சா? குரூப்ல வந்துருச்சு.
குரூப்ல வந்துச்சு, ma'am. Now she's sharing.
Yes, ma'am.
Yes.
Is it visible, ma'am?
Yes, yes, it's visible.
கையில க்ளோஸ் பண்ணிடு. அவங்க பேருக்கு போயிடுச்சு.
Shanti, ma'am, I have shared it, ma'am.
Yeah, madam. 1 minute. Okay. It's seen?
Yes,
Yes, yes. Yes.
Visible, ma'am.
Okay, am I audible?
Yes, ma'am.
Yes.
Okay, okay. Thank you. Sorry for this inconvenience. It's a very good evening from Taini, a place known for its greenery and fragrance. And at the outset, I thank Sambat Madam for including me in her first episode of this Pinnacle series. Madam is she's a great personality. This TNFOG is the brainchild of Sambat Madam, our Tamil Nadu Federation of Obstetrics and Gynecologists. And she is my well-wisher and a mentor. And for so many people also, she is the role model from Tamil Nadu. I wish her all the best for her future endeavor in Foxy. And with that, I welcome my expert and the panelist. And without much ado, we'll go into the topic. Hypertensive disorder in pregnancy remain the most significant unsolved problems in obstetrics, as we all know. And it's responsible for the 16% of the maternal mortality, and there is an increase in the perinatal mortality due to iatrogenic prematurity. And most of the deaths are preventable. And this is almost more than 2000-year-old disease, but still we are not in the better side of the treatment because the disease is multi-system disorder with multiple hypotheses, multiple etiology, and it has an ambiguous presentation and an unpredictable outcome. Primary prevention cannot be done because this is a placental disease and pregnancy cannot be avoided. And the secondary prevention is because of this, all this complex issue of the disease. And Madam has explained everything. So without much ado, we'll enter into the case. First cases. Case 1, 32-year-old second gravida, 36 weeks of pregnancy, went to an PHC with a complaining of headache. Her BP was recorded as 120/80. Patient was given is acetaminophen. At midnight, patient threw 3 fits at home and shifted to nearby hospital. Patient was irritable and her blood pressure is 180/120. At the private hospital, injection max of Pritchard's regimen started and tablet Lebetalon 100 mg was given and patient was referred to tertiary center. In the institution, when the patient was received, she is irritable and not answering the question. Her BP is still 170/110 and uterus is 36 weeks and fetal heart good and a posteriorly placed cervix and a phased nostril. She is not in labor. Now, Gayatri Madam, can you comment on this following what has happened to the patient and can you throw some light how to proceed? Am I audible?
Yes.
Yes.
Yes, you are very well audible, ma'am. Good evening, ma'am, and welcome you also, ma'am, as our moderator, and I welcome all of you all also in the today's panel discussions and the webinars. So I would like to proceed further. As see each and every case of seizure or convulsions for the occurring for the first time in pregnancy or in labor or in postnatal period, it should be taken as an eclampsia. It should be treated like an managed like an eclampsia we managed. So first of all, we would like to manage with the just like an eclampsia is an emergency, it is to be considered as an eclampsia emergency and call for help as said by the madam Sampath ma'am, that call for help 2222 from where this obstetric call has been given, and the senior call for our senior midwives, obstetricians, anesthetists, and all the neonatologists, senior neonatologists we should call. And first we will stabilize the patient, stabilize her normal like ABC. Airways should be cleaned and airway care for the airways and suction machine etc. should be there, and like ABC we manage breathing. Her breathing should be there to be noted, and like circulation, IV line with the catheterization, urinary bladder catheterization should be done, and general measures like that. And antihypertensive like magnesium sulfate should be given immediately, as a patient has already received magnesium sulfate. If it is not responding, seizures are still further continuing, then we'll manage the like Pritchard said by the madam, Pritchard's regime or the Justan regime is also there, but normally we use Pritchard regime, that is 4 gram, 4 gram in 20 ml, 20% initially IV bolus, and plus 5 gram with 50% in each of the buttocks immediately. If and we'll monitor her, monitor the patient's labetalol. She has, that patient has already got labetalol IV, and labetalol IV to be given antihypertensive. And if seizure has control, then monitor her blood pressure. If it is more than 170 and 110, then labetalol 20 milligram IV over 2 minutes. Repeat BP in 10 minutes also. Repeated 40 milligram IV. If BP is not controlled, still it is more than 160 by 100. Labetalol 40 milligram IV over 2 minutes. And again repeat BP every 10 minutes. If it is not controlling at all, it is the BP is 170 by 110, labetalol 80 milligram still to be repeated, and repeated frequent checking of the blood pressure in 10 minutes. Labetalol could be given 80 milligram IV over 2 minutes. Maximum dose 300 milligram is not to be exceeded. It is Yes, it is contraindicated in congestive cardiac failure, diabetes mellitus, asthma, and first of all, asthma patients should not be given labetalol, and the bradycardia is there. And the resuscitate, we should manage the resuscitate. There should be the eclampsia kit to be there, and with the resuscitative trays also to manage the eclampsia. And we'll proceed further to as this case is 36 weeks plus 2 weeks, so we should plan for immediate termination of pregnancy to deliver the baby.
Yeah,
because it's not in labor and cervix is posteriorly and os is not dilated, so we could plan for the cesarean section and deliver the baby. Termination is the definite treatment of this of the eclampsia, and if it allows, because pregnancy is already 36-37 weeks plus, so we could terminate and manage the with hypertension with further and monitor the postnatally also. Frequent BP blood pressure monitoring to be done, and
yes, madam. Yes. After this, I think you proceeded, you nicely explained, and I want to comment on the treatment previously, because the patient was recorded, her BP was recorded as 120/80 in the primary health center, and at home she threw 180/120. So the BP recording by the paramedical staff, we are not very sure whether she had done, because in the retrospectively in the audit we have found out that she had not at all recorded the BP, because her previous BP was normal. She had just
yes.
Yeah. So that is the first thing. And also in the private hospital, magnesium sulfate started, but in crisis, in this type of hypertensive crisis, it's a parenteral labetalol is the drug of choice. We want to get the BP immediately to calm down, so we prefer a parenteral antihypertensive. And magnesium sulfate is just an anticonvulsant; it is not an antihypertensive. So the management, as you told, that basic ABC along with an antihypertensive, preferably parenteral, because in this case, it only whenever IV access is not available, you can go for nifedipine. Otherwise, you have to go for a parenteral antihypertensive and anticonvulsant. As you said, this is the termination of the pregnancy is the treatment. You nicely explained this regimen and all. Pritchard's regimen is what we are following. And another flaw in this patient is multiple referral. When you know this patient is a case of eclampsia, should be treated in a tertiary center, you directly refer the patient to the tertiary center in spite of meddling with her in between. So these are the few things we have found in our audit.
But at case she presented with a headache, so that at PSC should have taken care of, because
the recording of the blood pressure is the cornerstone in the treatment of hypertensive disorder in pregnancy. It should be done with an utmost care and the proper technique. Because madam has already explained the technique, we are not going into that. And then, as you said, the patient was stabilized with the injection labetalol, and Maxel continued. So I think Kumar sir is there. So this is what happened in the institution. The magnesium sulfate was continued. The investigation has been done, because prior to that, you are interfering with that termination of the pregnancy. If you decide on that, if the platelet is very low, we will be in a soup. So that the investigation should be done prior to that, and patient is stabilized with antihypertensive, and Antihypertensive magnesium sulfate, it is used as only as an anticonvulsant, and you have to give an parenteral antihypertensive to make her blood pressure within normal limits. So this patient stabilized under general anesthesia. LSCS has been done, and a boy baby was delivered. Patient was put on elective ventilation and extubated, and CT brain taken and normal. Baby admitted in NICU, mother and baby discharged in good condition. This is the story of the patient. Now I want to
Madam,
Apurva Kumar sir is there.
Madam, I want to just
Yeah, you
tell
want-
something or query something. Madam, her first BP was 120/80, right? And it was considered normal. But we don't know what was her baseline second trimester blood pressure. If it has been 110/70 and all like this, and in now 20 above is considerable. So as a figure 120/80 sounds normal, but of her previous record is of only 170, 160.
Complaints of the headache. So if
Yeah.
she's having
So,
headache, she
yes, so
must have been checked with the other signs and symptoms of the eclampsia, pre-eclampsia.
yes. So this may be hypertension. If somebody would have seen her previous BP record and then with headache, it was a
Madam, you want to say there is an increase in the from the baseline blood pressure. That is
then
systolic more than 30, diastolic more than
maybe
50.
yes. It may
Maybe
be
from the
like
second
that.
trimester, even 140, 100 may be considered as an hypertension for that particular
That
patient. Because of
particular
this,
patient.
that's the point you want to impress.
Yeah,
So
because
that we are seeing some patient throwing fit with a normal blood pressure. Even with 140, 100, they are throwing fit because that BP would have been higher for the baseline
here
BP
for
for the particular patient. That's the point you want to impress.
yeah,
Thank
yeah,
you so much for that input, madam.
Ma'am, I would
Now-
like to add up one more point regarding this masked hypertension, which our ma'am Sampath ma'am very well mentioned regarding masked BP and this white coat hypertension.
Exactly opposite to that of the white coat hypertension, where the patient having hypertension at the doctor's clinic and she is having a normal blood pressure at home. But exactly opposite to that, the patient may be having a normal blood pressure in the consultation room and she is having a higher BP. But that masked hypertension is very rare. We should consider all the patient as an we are thinking about the improper checking of blood pressure at this point. Thank you for the input. I didn't want to raise up that point because the patient may have a wrong, and the audience may have a wrong idea regarding the checking of blood pressure. So, Sir Apurva Kumar Datta sir is there? Is not there? Shaili?
Yes, ma'am.
Yeah. Can you please, madam? Can you please take up this this thing? This what happened for the patient in the institution. Do you want to make a comment on this? And can you answer these questions? Take up these questions. Complications anticipated in the postpartum period. I think Sampath madam has elaborated.
Yeah.
And instruction to the patient at the time of discharge. You want to comment on this? What is done in the institution?
Ma'am, I think she was managed well because her BP was controlled and she timely termination of pregnancy was done, and we have given a healthy mother and healthy baby, so they have done a great job. At the time of discharge, ma'am has already explained.
Madam, are you happy about the anesthesia? What is the anesthesia we like to?
Ma'am, GA is the
regional. Regional anesthesia is a preferred anesthesia because induction of general anesthesia may end up with this because of the laryngeal edema. There is difficulty in intubation. But for this particular patient, because of the she had been there for a post-ictal stage for a prolonged period. She was irritable and sedated, so general anesthesia has been taken. Otherwise, regional anesthesia is the best for an hypertensive disorder in pregnancy.
Best.
Yeah. CT has been taken because patient was highly irritable. It is not mandatory for a neuroimaging in the post-operative period for routinely there is no need. But you should individualize the management. For this
in
patient,
this patient,
it was
as
needed.
she was in altered sensorium for a long time.
Yeah.
So it's important to rule out any cerebrovascular injury.
Yeah, cerebrovascular accidents. Yes, madam. Absolutely. Now, regarding this postpartum complications.
Postpartum complications, we should tell her that if she has any persistent headache, she should report any breathlessness or decrease in urine output. These are important things we should explain to her at the time of discharge. And she should report if she has any persistent headache, decreased urine output, breathlessness, like she may go in pulmonary edema, renal failure, or even any other neurological symptoms, because she may have any cerebrovascular accident later on also.
So she should
So,
go for investigation.
Yes, BP monitoring.
Yes.
Madam,
Proper-
anything you want to add?
Yes, I would like to add, ma'am, she should
Yes.
go for investigations and proper investigation postnatally, like liver function test, renal function test, creatinine level, and blood pressure, frequent blood pressure monitoring should be there. And
Yes.
if this creatinine level is, suppose it is 1 milligram, if it is a higher side of the normal level, but it is more for this patient also. So we should look for the liver function, serum transaminase level also should not be at or more than 70 milliequivalent per ml, millimole per ml, and we should, after proper investigation to be done, then maintain it. She should be maintained in a CC ward, like proper care and proper frequent vigilance is required, is needed.
she should come for a regular follow-up.
Yeah.
At the
BP
time of
checkup.
when we are, whenever her BP is well controlled, we will discharge her only at that condition.
And
BP is controlled and she will be on antihypertensive, so she should be counseled for regular
The
follow-up.
others to antihypertensive is a must in the postpartum period, because the incidence of postpartum eclampsia is very high, and the maternal death in the postpartum period due to hypertensive disorder is very high. So our management doesn't stop with that of the end of the delivery and discharge. It's continued in the postpartum. And in the postpartum period, early ambulation, adequate hydration, and correction of anemia, because anemia aggravates any hypertensive disorders, and prophylactic heparin, and adherence to antihypertensive. That's the point we want to address, because most of the patient will discontinue.
Thromboembolic, we have to take care of the thromboprophylaxis. We have to take care of it also, and the babies, we should take care of the babies, because patient has received IV labetalol, so baby may go on in hypoglycemia, hypocalcemia, hypothermia. We should look for the as a good baby care, fetal care, baby care also, in neonatal baby care also is very, very important postnatally.
Yes, madam. Baby should be taken care of in the postpartum period. So
Madam,
yes.
Actually, it is one more point in that in our society, if male child is there, her BP is automatically gets settled down. Fun apart, but she was managed well.
Yes, madam. But I think we have we have to go through all the hurdles. So now we should not say like that only male child is given importance. It's still there. It's still there. It's still there. I do accept. Now the question is, we have seen what are the complications and how to prevent that. And we have to talk about the contraception, because that is more important. The patient should be covered with one of the contraception. All patients should receive the information about the signs and symptoms of preeclampsia in the postpartum period, and she should be tagged with the person who is going to look after in the postpartum period, and should be informed about the signs and symptoms. Actually, the discharge summary is your passport, and the patient should receive all the information that is needed. So now, Shika is there, madam. Dr. Shika. She's not there.
Yes, ma'am.
Yeah, you are there, sorry. What's the outcome of the future pregnancy, and what's the long-term sequelae to the mother? Why we are bothered? Whether previously we used to teach our students like that once the delivery is completed, the patient is free of the symptoms. So this is the disease is limited to that of the pregnancy. But now we have found out there is a long-term sequelae to the mother. So she needs a regular follow-up. What's the outcome of the future pregnancy?
Then in pregnancy also she can get hypertension.
Yeah.
And even she can get chronic hypertension also when she
Yeah.
goes in 40-45 years old.
Yes, yes.
In that
That's the most
case also
important
the-
point. Residual
Yeah.
hypertension, it's 40% of the patients will be going for residual hypertension. Yes, the risk of subsequent pregnancy is recurrence is also 20%. And
Yes.
early onset of preeclampsia is 25%. And non-severe preeclampsia is 5 to 7%. So the pre-conceptional counseling is more important. Even without hypertension, the patient, the baby may go IUGR in the next pregnancy. So they need a long-term follow-up and counseling. These people are going for non-communicable disease in their later age group. So cardiovascular disease, neurovascular, metabolic, diabetics, and renal disorders are very common in this patient. So the message from this case is that all paramedical staff should be sensitized about the importance and trained in the appropriate technique of BP measurement. And patient should aware of the warning symptoms and parental antihypertensive in case of hypertensive emergencies. And should not be considered as a self-limiting disease. Annual medical review is advised for long-term follow-up, and healthy lifestyle should be adapted, like exercise and eating well and aiming for the ideal BMI. So I think the message has been conveyed in a proper way. Yes, shall we move to next case?
Yeah.
Yes. This is case 2, 30-year primigravida. I want an opinion from Shanta Vibala. Can we go to the next case, or you want to add up some points?
Ma'am, this case discussion was fully covered, ma'am, regarding it's a case of eclampsia, which is stabilized and managed with as a routine with Maxelf and Labetalol. And I would like to add up. So you have covered this heparin prophylaxis also, considering the embolism risk increased with the hypertensive patients. So heparin prophylaxis must be followed in all the cases. Then regarding the discharge policy, ma'am, for any post-operative cases or for postpartum women, the discharge should be planned only after 8 days because there is a chance for rise of BP up on the 5th or the 6th day. So that should be caution. And yearly discharge is not advisable in any case of gestational hypertension. So that's what I would like to add up now.
Yeah. So
Yes,
your institution policy is 8 days. Each institution have a strict policy regarding the discharge, whether the patient can be followed up at her home or in a resident by a able medical person, then we can think about the discharge. Or otherwise, we can discharge her according to your institutional policy. The patient should be followed up. That is our ultimate aim. Any opinion from Gayatri, madam, regarding this? You wanted to tell something? Okay, then we can move on to the next case.
Madam, I have a query.
Yeah,
You
madam.
told about heparin. For how many days we can continue with the heparin, injectable heparin?
Heparin, madam. Heparin 5,000 units for 5 days. For 5 days.
Okay.
Okay. Then,
but if the platelet count is and prothrombin time
I'm not audible, madam.
INR is normal.
For 5 days, 5,000 units heparin, no need, madam. You can check the coagulation profile earlier, or you can even go for low molecular weight heparin.
Yeah, generally we use low molecular weight. Yeah.
Because in government setup it is not available, we are going for this routine heparin, conventional. You can in a private practice you can go for a low molecular weight heparin also. So this is the case 2, 30-year primigravida, 32 weeks gestation, and she is on routine AN checkup. She had no complaints, and she has come for a routine antenatal visit. Her blood pressure was 160, 110. Urine albumin is 1+. Per abdomen, uterus 32 weeks relaxed, and fetal heart rate is 140 per minute, and patient is not in labor. This sort of cases which is borderline, she's 32 weeks, not late preterm, and her blood pressure is high, but urine albumin is only 1+. We are considering 2+ as a serious condition. And this fetal heart is good, and patient is not in labor, but her blood pressure is 160/110. This scenario, if the patient present like this, how to proceed? Nivedita, are you there?
Ma'am. Good evening, ma'am.
Good evening.
So I'll consider this patient as a severe preeclampsia since BP is 160/110 and proteinuria is there. So I will admit the patient and secure the IV line, and I'll send all blood investigations like platelet count, complete blood count, including platelet count, and renal function test with the serum creatinine and protein creatinine ratio, LFT. And then I'll ask for any imminent sign for leading questions. If and I'll make the maternal status stable, like giving IV labetalol protocol. If ma'am has well explained about the IV labetalol protocol. So if she get controlled with labetalol, then I'll give corticosteroid and monitor the fetal status and wait for I'll buy some time for the fetal maturity, lung maturity, and I'll proceed for termination of pregnancy. If BP is under control and the fetus is also in well condition, and fetal status like your umbilical artery Doppler and everything was good, then I'll proceed till 34 weeks and then plan for. If needed, med-self regimen can be given for neuroprotective condition for the fetus state.
For 160/110, you want to give a prophylactic Maxel, or you want to go for a neuroprotection? For both.
For both.
For both. Admit the patient. You do an HDP panel, entire HDP panel, urea creatinine and liver enzymes, electrolytes, coagulation profile. Yeah.
All blood investigations, everything.
Everything you have to do, because even with that, the patient may be HELP syndrome, what we are missing. Without an investigation, we can't, with a simple blood pressure, we can't say. So you have to do the entire investigation, and you have to treatment of hypertension. As we told earlier, 160/110, we have to go for a parenteral antihypertensive. That is very ideal. That will reduce the blood pressure. So in an hypertensive, this is considered as hypertensive urgency, where there is only blood pressure, no end organ damage. So hypertensive emergency is with the blood pressure, there is an end organ damage. We have to interfere with the we have to think about the termination of pregnancy. When there is an urgency only, when the investigations are normal, patient is having only blood pressure, no symptom, that is called hypertensive urgency, where you can think about the conservative management. So this patient, her investigation is like that, CBC, platelet is 3 lakhs and her coagulation profile INR is 0.81, LFT is normal and within the range, RFT and electrolytes, uric acid, LDH, urine albumin is 1+, fundus is normal and Doppler study is normal. So with that, I told already, usually when the patient's first presenting with 160/110, do you want to wait for 4 hours apart? That is the strategy what we are using to define hypertension. Will you wait for 4 hours for in this patient, or you will repeat the BP within when the patient is first presenting with 160/110? So you have to
repeat within 15 minutes.
Within 15 minutes, you have to record the BP. If it is still 160/110, then you have to start. So this all discussed with madam. So I'm not going into detail. Tablet labetalol is the drug we are using widely, and nifedipine is also we are using, and the second drug line of drug. And methyl dopa, previously we used right and left. Now we have restricted use because of this emergence with the tablet labetalol. We are very comfortable with the labetalol. And what's the target BP you want to achieve? Bhuneshwari is there? No.
Yes, ma'am.
Bhuneshwari?
Yes, ma'am. Am I audible, ma'am?
Yeah, you are audible, very much audible.
Ideally, the target BP should be less than 135. Systolic should be less than 135 and diastolic should be around 85, ma'am.
Yeah. Previously, we used to say 140/90 is okay, but
Yeah.
now the CHIPS trial says that it needs a tight control because of
Tight
this.
control of the
That will reduce the risk of maternal morbidity in this patient.
yes.
So this patient, for this particular patient, it is controlled with labetalol 200 milligram BD and added up nifedipine 10 milligram BD. She is on dual antihypertensive and she has been monitored, admitted, and her investigations or laboratory parameters are normal. Now, expected management versus immediate delivery. Nivedita already pointed out, I want to, certain protocols are normal, I want to wait. So what is your opinion, Bhuvaneshwari?
I will go for expectant management, ma'am. The HTP panel should be repeated after 48 hours. If it is normal, we have to for fetal lung maturity, we have to go for antenatal steroids, either injection dexamethasone 6 mg IM 4 doses 12 hours apart, or injection betamethasone 12 mg 24 hours apart 2 doses, and maternal monitoring of BP. Fourth hourly BP should be monitored, and her blood investigations like CBC, RFT, LFT should be repeated after 48 hours, and that should remain normal. And fetal surveillance biophysical profile, as you said, the per abdomen is 32 weeks, which is corresponding to her period of gestation. That rules out ILGFGR. So you have to monitor the fetal status with the biophysical profile and fetal Doppler, umbilical artery Doppler.
Okay. So this is ACOG guidelines. As madam told, if it is before that 28 weeks, then you can deliver. It's more than 34 weeks also you can deliver, because in between we are stuck up and we want to give a good neonatal outcome. We want to avoid the neonatal admissions. So if the patient is asymptomatic with the blood pressure is based only 160, 110, and when it is controlled, you go for an expected management. This is the ACOG guideline says. So now patient was closely monitored. After 8 days, there is a rising trend in the LFT. So labor was induced and patient delivered labor naturally, a girl baby with a good upward score. So this is almost like a tight rope walk. We have to balance. We have to endanger the maternal life for the sake of the baby. So we should be very careful. The case selection criteria should be very strict. And the place where we are doing this is more important, where you are having everything for the management of eclampsia and all the complications related to hypertensive disorder in pregnancy.
Ma'am, I have a query. Ma'am, would you like to involve physician, or would you like to take some physician's opinion during these days?
Who for whose opinion, madam?
Physician's opinion.
Physician opinion, madam. Okay, madam. Usually,
generally for the sake of medico-legal, this thing means it is considered given that she's having hypertension. We are going to
for fundus examination, definitely we are having an ophthalmologist opinion. And regarding these parameters, as long as within normal limits, laboratory parameters, if it is LFT raised, then we have to go for a physician opinion. For renal parameters elevated, nephrology opinion, like that. But as such, for a preeclampsia, for simple control of blood pressure, we in our institution, we ourselves are managing. That is the protocol followed by Tamil Nadu government also. For a simple preeclampsia, without the added complication, it is an entirely OBGYN opinion regarding the control of blood pressure. That's what our government is policy, Tamil Nadu government policy. So we are not asking for physician opinion unless otherwise it is needed.
Okay.
Can we predict the risk of progression? This is the newer aspect of this disease, as madam already focused on this question. I want to ask Bhuvaneshwari, can we predict the risk? The patient is here with a BP of 160, 110. Now we are controlling her with the tablet labetalol and tablet nifedipine. Her blood pressure is normal. But still we are panicked because it is she is like a time bomb, because BP alone is an iceberg of the disease. The entire pathology is going down in the body. So anytime she will go into for any complications of hypertension. Can we predict the risk of progression apart from clinical and laboratory parameters? Is it any method, anything
It was mentioned by Sampath Kumari ma'am, SFLT PLGF ratio. That
yeah.
should be less than 38.
Yeah. That is the test for a higher economical status. And for middle class and low economic status countries, this is the mini PS model. Madam talked about this also. That is only, this is an machine learning models. This is a mobile app where we can enter the variables and it will give you the opinion whether the patient will go for complication within the next 48 hours. This is the mini PS model. And these are all the variables. Can you read this? Can you read this? Is it?
Yeah.
Yeah. Mini PS. Can you read this?
Yes, mini PS calculation. Asking for the gestational age at admission in ADVI. Any previous deliveries more than 20 weeks gestation? Is there any history of chest pain or dyspnea, headache or visual changes, vaginal bleeding with abdominal pain, what's her systolic BP, and dipstick proteinuria, her SpO2, and we'll get a calculation, which is a so
this is the
option
mini
based.
pairs calculator that can be done very easily by the any setup. So full pairs is added with the laboratory tests, platelets and creatinine is added. So you have to enter, the app will give you the calculation whether the patient is going for this complications of preeclampsia. So this is somewhat a program that sensitize the woman and the attending paramedical and medical person. So enable the, at least we can have the knowledge about the risk of the disease and a prompt referral of the patient. Timely referral, that is useful by doing this. And as you said, this is the name balance, and madam also talked about this SFLT and PAGF ratio. If it is more than 85, the patient will end up with the complications within 7 days. This is an imbalance. You talked about this Bhuvaneshwari, so we'll move on to that. Anything you want to add up for this glycosylated fibronectin?
No idea, ma'am.
No idea. This is a simple test. Like this is an elaborative laboratory test of calculating SFLT and PAGF ratio. And this glycosylated fibronectin is a test that is like a this point of care test. Simple strip can be introduced into the machine so that you can have a capillary prick, and it will identify the risk for this thing, complications. So this is the message I want to give, because we are very anxious. We want to give a better maternal outcome, but it should not be in the trade-off of neonatal issues. You have to wait patiently. I know that will have a better maternal the obstetrics in a future career. If the baby is lost in the first delivery due to preeclampsia, the patient will have the incidence of preeclampsia in the next pregnancy. Chance is very high. And she is going to have the same complication in the next pregnancy too. So you have to wait and you have to give a better neonatal age. That's the point I want to stress upon. Can we move on to third? Vibala, you want to add something for this second case discussion?
This case of early onset preeclampsia that was very well discussed with many recent advances, including this mini pairs and full pairs model for predicting the risk. So that is the need of the hour, because early onset preeclampsia is on the increase nowadays. More of cases with so we have to have a concern over the neonatal aspect also. So that will be very useful if adopted.
It said that it's only 85.5% accuracy for many pairs, but still it's when we are using that, we have some knowledge. The patient also is aware of her disease, and the attending person is also the family, the community, everything is some sort of spreading of knowledge. So that a point of thing I want to impress.
Ma'am, but I want to say one thing.
Yes,
Ma'am,
madam.
this thing, but this thing can increase the anxiety in the patient also.
Yes,
Because the
madam.
patient, it can increase
Both aspects are there. Patient should
Yes.
not be ignorant. She should not be anxious. That all depends how we are going to counsel the patient. The patient should not be ignorant about her disease. At the same time, she should not be anxious about the disease. That all depends on how the attending physician counsel the patient. That's
Yes,
a more important thing in this point. Anything should be added by anybody? Okay, next case. Shall we move on to next case? So this is case 3. She is a primey, 33 years, and her BMI is more than 35. She is a twin pregnancy, DCDA twin, both cephalic, at 34 weeks with a blood pressure of BP 150/100. HTP panel is normal. Patient went in for spontaneous labor at 34 weeks and delivered. At the time of delivery, she had atonic PPH, naturally expected in a twin. So managed with uterotonics and 1 unit of fat cell transfusion has been given. On second day of delivery, her BP is managed with antihypertensive. BP is 140/100, but urine output is nil, in spite of injection, furosemide, and fluid challenge with increasing renal parameters. In this patient, this is a case we are normally saying with the increasing that IVF procedures. So she is with the increased BMI and twin at 34 weeks. This should have been avoided, because nothing can be avoided in this patient except for the appearance of preeclampsia, because atonic PPH we are anticipating and we are going to manage. Except preeclampsia, we cannot avoid anything in this patient. How can you avoid this preeclampsia in this patient? Any predictors for preeclampsia? Madam Ujjwala, madam is there?
Yeah, I'm there.
Yeah. Can you please take up there?
Yeah. Madam, she's already the predictor point, so we can see she's primary with her BP is high. Then her age is also more. Then her BMI is also more. Then there is a history of PPH also is there. So these are the these are the factors we can predictors of, we can say, of this case, where she can for acute kidney injury is maybe the cause and predictor factors for that.
Yeah. Justosis score, as madam explained, this is the justosis score. It is simple. It can be done for every patient who is attending the outpatient clinic at the as early as booking of the pregnancy. And if the age is more than 35, it comes around score around 1. So this patient is a twin pregnancy. Her score is already 2. So she is almost more than 3. That's a case of at risk of preeclampsia would have been identified earlier, and she would have started on preventive measures. So that's what I want to say, because PPH would not have been prevented in this patient.
Yes.
So another madam is not there. Neha madam is not there. So Nivedita, can you take up this thing? What are all the components of this prenatal screening? What we are doing now? What is in our limits? Because this is an, as I told, machine learning models are there. With more variables can be incorporated into the model, and we can get the result immediately. This is our artificial intelligence era. So can you make what are all the things you have to useful for prenatal screening at the first visit?
We have to go for a screen for the age of the patient, and then
maternal characteristics we have already seen. Apart from that, MAP has any role? Mean arterial pressure has any role on the PLG?
Yes, ma'am. Obviously, mean arterial pressure should be monitored.
Yeah, madam already told.
And PLGF in 11 to 13 weeks itself, we can see a PLGF and a Papa.
Yeah. Along with the part of aneuploidy screening, we can do
screening down. I mean, a double marker. We can give a test for that.
Yes. So any single test is not useful for the risk assessment. A combined test. Yeah, because the disease of variable etiology and we are having variable markers, so we cannot use a single marker or single test as a predictor. So what's the prevention of preeclampsia? Shaili madam is there. Shaili. Shaili is there, madam. Shaili is not there. Shika, madam is
Neha and Shaili is not there, I think.
Okay. Then we can ask, Sar is also there or not there, madam? Apurva Kumar.
Shika has not joined. He has
Not
mentioned.
Ma'am, I'm here. Dr. Shika.
Oh,
yeah,
Shika
madam.
is there. Then she can.
Madam. Sorry, we have forgotten you. How can you prevent that preeclampsia when you find out this patient is high risk for preeclampsia? Any drugs we are using?
Yeah,
How
ma'am.
about aspirin?
We can ask tablet ecosprin. As we know, if she's pregnant, we can start ecosprin from the first trimester. And 150 milligram.
Madam Sambat Madam has noted something 164 milligram. But
Yeah. But that today only I saw this. I didn't know this.
Yeah. Okay.
Yeah.
What we are following is 150 milligram. It should be started very early. That's what the thing I want to impress, because that tropoplastic invasion, first wave of tropoplastic invasion occurs around 12 weeks. So if we start aspirin in the later phase, it won't be effective. So should be started as early as 11 weeks, in and around 11 weeks. Should be taken at night. What about other drugs? You recommend calcium?
Calcium, vitamin D3 we can give.
Yeah. Vitamin E.
Calcium and
Vitamin E, C.
Alarginin.
Yeah, only these two drugs has been proved as efficacy over the prevention. All the other drugs, vitamin C, D, E, and antioxidants, everything people are using, but they are not as such recommended by any recommendations. So these are the two drugs recommended by.
I want to add that if there is history of IUGR due to preeclampsia, we can add low molecular weight heparin also.
Okay. Low molecular weight heparin for?
Ma'am, if there is any history of IUGR in previous pregnancy, yeah.
Madam, even if we suspect preeclampsia, even we can advise and counsel her about her lifestyle also, about her diet since beginning. She seems to be obese, so some exercise, positivity, some diet which is only healthy, will not increase her weight. All these things we can counsel her since beginning with folic acid supplements and all.
Diet advice as usual we are giving, because we don't want the patient to get overweight, and aspirin prophylaxis is an accepted one. Regarding the heparin for prevention of preeclampsia, it's not. I think heparin is not recommended. Shandabala, what is your opinion?
Ma'am, not for prevention of eclampsia, but if there is history of IUGR and history of bad obstetric history due to hypertension.
Yeah, if it is due to bad obstetric history, then even applies negative, we are advocating heparin. But without, it's a primary, whether heparin is routinely used, except for an IVF conception. It's a primary with the high risk for preeclampsia. Are we routinely using heparin? That's the question.
No. Not in this case, ma'am. Not in this case.
Okay. If it is an IVF conception, people are considering about heparin because it's a blood thinner. And otherwise, heparin for prophylaxis for other cases, routine cases, because it is a simple scoring is high, I think heparin is not recommended. Aspirin and calcium is the recommended drugs for prevention of preeclampsia.
Okay,
and this patient, as I told,
Sorry to interrupt, ma'am. We're running
Yes,
short of time.
Yeah.
Wind up?
Yeah,
Yes,
we'll
ma'am.
finish it off. I'm
Yes,
rushing. The causes for AK in this patient, I think I'll finish off, because the disease itself, and I want to make the point that hypovolemia, that's the reason, because she had atonic pH and it is not the correction has not been done. So patient referred to nephrology department, and the biopsy showed a renal cortical necrosis. She had 22 cycles. This is our own case. And this is, I want to say, preeclampsia cannot be predicted by single test. Madam also emphasized this point, and combined test is necessary. Better prediction. Yeah, hopefully, more researches are going on so that we could help us to focus on the good antenatal care. So we need protocols, we need checklist. And Madam was telling about eclampsia. I was thinking about this checklist. That will be easier when you are having the checklist. And it is always a team wherever, as Madam noted, you want a physician or a nephrologist. Everybody should be there for your care. And audit is more important. We have to audit ourselves so that we can prevent the same mistakes again. And documentation is more important to save ourselves and also the patients. And when we plan for everything, we can achieve that. This is for Sampath Madam too. If you plan for in a proper manner, even the difficult pathway become easier and you can achieve your goal. All the best for you, madam. And this is, I want to finish it off every time with this slide. This is a sunset or sunrise. You can't say without seeing the full picture. So don't go along with BP alone. You have to see the patient with the entire as a patient as a whole. Laboratory investigations and as a whole picture. You have to see the edema. You have to look for the complaint. Not only this blood pressure, because blood pressure is only a tip of the iceberg of the disease where the entire pathology is going down every day. Every day the disease is getting worse and as we are getting aged. And to see the patient as a whole. And stop PH mortality is then goal for Tamil Nadu government. And also I hope that we should all work together to achieve this. Thank you for the opportunity.
Thank you so much.
Thank you, ma'am. From two great icons, I got a lot of. There was an elaborate discussion by Sampath ma'am and Dr. Shantirani ma'am, and I think many of us would have benefited because it was very elaborate and many recent advances has been discussed, practical points also. And I would like to thank Sampath ma'am, a great academician, and I could see even her good heart, even not having much interaction with her. So I'm a great admirer of your daily quotes you're posting in the group, ma'am. Thank you so much for me, for this honor. Thank you.
Thank you for
Thank
joining.
you for the lovely panel, ma'am. I thank our chairperson, our
Dr. Madhumita, treasurer of Salem, for vote of thanks.
Yes, ma'am.
Stop the slide sharing so that I can see you all. Without
Yes,
seeing
ma'am.
you all, I was talking to the screen.
Yes.
You have conducted very
Sir is
nicely.
here. Hi, sir.
Hi, sir. Hi, sir.
I'm extremely sorry. I just stuck in one of the topic for today, the severe preeclampsia.
So you prevented eclampsia.
Yes, previous one LSCS with the severe preeclampsia and just had the cesarean of that patient. So I'm extremely sorry I stuck in that emergency. I am 100% sure that will be a wonderful panel. And thank you so much, Santi ma'am, for this, and Sampath madam for organizing this webinar. And ma'am, just I want to add one thing, because ma'am, it's a very small place. And I am is there, our president. My place and working place is still beyond the main city. So we have a lot of patients, the tribal patients, and who are directly land up into the at a advanced stage of labor in a case of preeclampsia. So what madam has Santi madam has already stated very well, that prevention is definitely very better. And ma'am, literally in few Jharkhand, it's from previously, now the improvement is much there, but still the simple hemoglobin and blood pressure level measure is really not, and especially the tribal and the village area, it is still really need to be there. And Gayatri ma'am she was also is in a government setup, so she must agree with me that it is really challenging for all of us, because the patient lost to follow up, and this is the one thing. So thank you so much, Santi ma'am, for your wonderful panel, and thank you, Sampath madam, and definitely Madhumita is a treasurer for your society and definitely for Foxy. She's super dynamic, super active.
Thank you so much for your
Thank you so
kind
much,
words.
sir. Even though you joined late. Yeah, thank you all the panelists. Thank you, Sampath madam. Thank you all the panelists.
Thank you, Arun Shanta was telling yesterday. He is coming from Guwahati, no, Arun Barua, sir.
Yeah, absolutely.
He was telling you, people are talking about the main city. And see our patient, Assam patient in the periphery. What you told, he told. That is also from the periphery. If you are reducing the mortality to 5 also, it is 5% also, it is a good work. That's all. Now, Jharkhand, Assam, everyone has reduced their MMR. Definitely.
Absolutely.
Okay.
Thank you so much, ma'am. Thank you so much, ma'am.
Thank you, sir. Thank you so much for joining. So, moving on to the vote of thanks. At the end of this 1.5 hours of such an informative session, first and foremost, I would like to thank Sampath ma'am for bringing us this wonderful webinar today, and also and organizing this and bringing together 4 societies from 4 different corners of India. Thank you so much, ma'am, for the opportunity. And a big thank you, thanks to our chief guests, Dr. Hema Divakar and Dr. Rosa Oliai ma'am, for their blessings, and our guest of honor, Dr. Shubha Singh and Dr. Datta, for coming and blessing this evening. And I would like to thank the presidents and secretaries of the 4 societies: Jaunpur Society, Dr. Shubha Singh and Dr. Shaili Nigam; Dhanbad Society, Dr. Gayatri Singh and Dr. Neha Priyadarshini; Thane Society, Dr. Datta and Dr. Ujwala; and Teni Society, Dr. Shanta Vibala and Dr. Nivedita, for collaborating and sharing your inputs and involving all your societies today. And I would like to thank Dr. Gayatri Singh for being the chairperson for this first session, and our moderator Shanti Rani ma'am for this really vibrant panel today, and expert Dr. Shanta Vibala ma'am. And I thank our expert panelists who made this panel into such a informative and lively one: Dr. Apurva Kumar Datta, Dr. Shaili Nigam, Dr. Shika Shukla, Dr. Ujwala, Dr. Gayatri Singh, Dr. Nivedita, and Dr. Bhuneshwari. A big thank you to one and all. And last but not the least, I would like to thank our dear delegates for joining in such a large number. And I would also like to thank Sahiti and Priya for your technical support and helping us to move on with this webinar without any glitches. Thank you, one and all. Hoping to meet for the next Pinnacle webinar. Will be announced in maybe in another week.
No, every day, every month, the second Thursday will be obstetrics, 4th Thursday will be gynec.
Yes, ma'am.
For a month, 2 sessions.
Yes, madam.
Yes, ma'am. We'll post the updates in the group. We'll keep this the same group running and we'll just post the updates.
Thank you so much, madam. It was a fantastic